Welcome to a 1-hour Pallium Project archival podcast of a professional development event. The views presented in this session are those of our expert guests and participants from across Canada. In this podcast, Jackie Peden, an advanced practice nurse in hospice palliative care, interviews Dr. Mary Vachon, a psychotherapist who is professor in the Departments of Psychiatry and Public Health Services at the University of Toronto and clinical consultant at Wellspring. This session is called Avoiding Burnout and Compassion Fatigue, Feeding One's Soul.
What we're talking about is burnout. So can you tell me what is burnout? And is this a problem when providing care?
I think it's good, Jackie, to give a bit of a history about the concept of burnout. It was first conceptualized by a physician, Dr. Friedenberger, in the 1970s. He was working in an urban clinic in New York and working huge numbers of hours, middle of the night, all this sort of stuff, and was all organized to go on a trip with his family, came home late, fell asleep, and didn't wake up for a couple of days. And when he woke up, he was incredibly depressed, unable to function. And he began to conceptualize what he was going through as being similar to the urban landscape that he was seeing in the slums of New York, where apartment buildings were burned out. There was just a shell left, and the whole inside was gone. So that's the image that we start with back in the 1970s. And now we define burnout as in a couple of different ways. A couple of working definitions would be the progressive loss of idealism, energy, and purpose experienced by people in the helping professions as a result of the conditions of their work, or a syndrome of responses involving increased feelings of emotional exhaustion, negative attitudes towards the recipients of one's service, and we call that depersonalization, and a tendency to evaluate oneself negatively with regard to one's work, and a feeling of dissatisfaction with accomplishments on the job. Now, I've been looking at issues of burnout in health providers and hospice and palliative care since the early 70s. And for the most part, in fact, our burnout is less than it is in a number of other areas. But there is some beginning indication that this burnout might be getting to be a somewhat bigger problem as the financial resources are becoming somewhat more limited and people are having more and more work to do.
So why do you think that there's less of a problem with burnout in hospice palliative care?
Well, I like to think that some of the early work that I did way back when we were studying the staff of the Royal Victoria Hospital, the palliative care unit, which opened in the 1970s, what happened there was that the organization put into effect support systems for the staff. And right from scratch, there has been the assumption that you need to have support to do this kind of work. And I think that's a good part of what means that we have less stress. That enables us to, hopefully, not always, have better relationships with our colleagues, which is an essential part of avoiding burnout, and to feel that we're doing things as a part of a functioning team, which is also a helpful way of avoiding burnout.
Yeah, that makes sense to me. The image that you provided of a burnt-out building is quite powerful.
Isn't it? That's why I thought I'd start that way.
That shell of a building.
Yeah.
What do you think causes burnout in people who are working with the dying?
Well, there are lots of different ways of looking at burnout. And Christina Maslach is a researcher who has been working in the area for many years. And she's begun to pull together the various components of what leads to burnout. And it's not, the dying patient work is generally not the big problem. We can talk about that. But she says, essentially, that there are 6 areas that are important to people. And those areas have to do with the workload that people experience, the kind of control they experience in their work, the rewards that they have, whether or not they feel that there's fairness in their system, whether or not they feel they're part of a community, and what their value systems are. Now, we can talk through each of those things if you'd like, or not, whatever makes sense to you.
Maybe, sure, briefly.
Okay.
Yeah.
So essentially, what happens with workload is if there's too much work, particularly in palliative care, because we're trying to develop relationships with people, we don't do very well. So we need to figure out how much work is enough work and how much work is too much work in palliative care. Hospice and palliative care nurses used to really pride themselves on having lots of time to spend with patients, but now as this doesn't always happen, that can be a problem. Now, control is the second area, and control means that if we don't have enough control over our work environment, that can give us difficulty. So in some of my own research and some of the research of other people, examples would be such as nurses being expected to perform procedures in the community when they don't have enough training, or being responsible for handling the pain of patients in the community without the kind of backup that they feel is indicated. Mm-hmm. One of the nurses I interviewed for a recent article said, and I'm going to quote her, "I'm the admitting nurse. I have so many hours to get a patient on the service. I can't predict if the doctor will call back. He may not call back till the next day. It can happen that I'm at X hospital, the patient is going home. I call his doctor and tell him the patient is short of breath and there isn't an order for Ativan. The doctor may not call back until tomorrow. We could use our own hospice doctor, but I don't want to make the referring doctor angry." So nurses have real difficulty in this situation. Another nurse spoke about the fact that when she reported to a community physician that a dying patient was in severe pain, the doctor said, and the nurse felt that the patient needed his pain meds increased. The doctor said, "Who am I treating? You were the patient." Mm-hmm. Now, a sense of rewards, if people feel that they're not getting either the financial rewards or the emotional rewards from their work, it can be a problem. If our work isn't getting recognized, we can have difficulty. Mm-hmm. Our sense of community, part of the difficulty is pretty consistently our team is both the place where we get our most support and the place that the group that gives us the most difficulty. And so when that community isn't working well, we're not working well. A sense of fairness is a major issue for people. And if people don't feel that their assignments are fair, their hours are fair, they can have trouble. And then values. Are we really able to do the kinds of things that we feel we should be doing? Are our institutions living up to the mission statements that they have? Mm-hmm. If we don't feel things are working, it's a problem. And then with regard to death and dying, that can be a problem for us, but also we choose to work with dying people, and it has a lot of rewards for us as well. So while in some situations dealing with the dying is associated with burnout, in other situations it's a major source of our satisfaction.
Right. Yes, I think that it's the one area where it doesn't take very much to make a difference in someone's life.
This is the thing.
Yeah, right. Are some people more susceptible to others?
Well, yes, the evidence generally is that people who are younger, now it's interesting, as I age myself, I guess I can no longer be considered young by any criteria. However, in some studies, younger people, those under 30, have more difficulty with burnout. In other studies, those younger people, those under 55, have more trouble with burnout. It's as though the people who stay in the system for a long period of time have learned enough coping mechanisms that it's not a problem for them, and they don't seem to burn out. They're often continuing to do the work because they love it, or conceivably, maybe they're just not invested and therefore not burning out. But in general, younger people, women, those without some kind of a spiritual belief system can tend to have more difficulty, and those who tend to make their work their entire life and who expect to receive all their rewards through their work situation can have trouble. And additionally, those who have a lot of job-home interaction. If your family really doesn't like the fact that you're doing this kind of work, it can make for difficulty. If you have huge responsibilities at home and huge responsibilities in the work situation, it can make for difficulty.
Mm-hmm. How would I recognize that I was burning out?
Well, there are a number of symptoms that various authors have picked up over the years, and so I'll go through a list of them, and people may find themselves saying, well, I have this and this and this, but see how many you have. So a list of symptoms would be fatigue, physical and emotional exhaustion, headaches, GI disturbances, weight loss, sleeplessness, depression, boredom, frustration, low morale, job turnover in a community, in an organizational setting, people just not able to perform in the same way, people just not able to have the kind of relationships that they used to be able to have with patients, and feeling less satisfied, not wanting to spend time with patients, not wanting to come to work. And then another sign of burnout is an inability to leave work, so that your work just expands and you're spending your whole life working, not getting much done, but you just can't even leave the place that you're not interested in being in.
That's interesting. I didn't realize that was one of the signs.
Yeah, it can be. Yeah, so everybody can sort of think, ooh, now there are certain signs I wasn't aware of.
Right, that one in particular.
Right.
I hear an awful lot about compassion fatigue. What is it, and how does it differ from burnout?
Well, people really came to not like the term burnout in some ways, and so a researcher, Dr. Charles Figley, developed this term, compassion fatigue. Now, its technical name is secondary vicarious traumatization, or secondary PTSD. And the idea behind it is that we as caregivers can become traumatized through exposure to the problems that we see with our patients. And so compassion fatigue has some of the same characteristics as burnout. You can see people with compassion fatigue feeling depression, anxiety, hypochondriasis, combativeness, the sensation of being on fast forward, and an inability to concentrate. But Garfield and his colleagues state that in contrast to somebody who has burned out, the caregiver with compassion fatigue can still care and be involved. That's one of the key variables. Now, there's a clinical nurse specialist by the name of Wright who works in the UK, and he gives some of the following signs of compassion fatigue. Just no energy for it anymore, emptied, nothing left to give, not wanting to go there again, feeling depleted in every dimension, too many questions and no answers. Why am I doing this? So these are some of the concepts, some of the manifestations of compassion fatigue. And many people would far rather think they have compassion fatigue than that they're burned out.
Stress is also, when we talk about burnout or talk about caregiving, stress is associated with that. And I'm not so sure that is stress really that bad for, I think I know there's different types of stress. So can we talk a little bit about that associated with caregiving?
Sure. I mean, if you want to start by different kinds of stress, many years ago, I was at a workshop called together by Hans Selye, the great stress expert. And he said at that time that if you love your job, it doesn't cause you stress. And he talked about the fact that he had been diagnosed with cancer, told he had a year to live, thought, what do I want to do? Well, I want to write about my work. And so he did that, and at the end of the year he was just fine, and he continued to live for about another 13 years. And that concept of if you love your work, it doesn't cause stress is a really important concept. And a number of authors have tried to look at the concept of what gives, enough about the stress stuff, what gives people satisfaction in their job. So Linda Christensen, who's a Canadian nurse researcher working now in Australia, and her colleagues talked in terms of the vitality of palliative care. And they found that the staff that they interviewed spoke about something called vitality, which they defined as the capacity to live and develop, which is associated with energy, life, animation, and importance, and said that that was the core meaning of palliative care. This way of living involves unity with the self, being touched to the heart, and personal meaning. And the caregivers that Linda and her colleagues studied found that the lessons that they learned from their work added meaning to their personal and professional lives. These people were animated in describing their work. They articulated the importance of the experience in terms of personal growth for patients, families, and caregivers, and I think many of us see this all the time. And these staff felt that their interactions with patients, families, and their colleagues were meaningful, and that the workplace was described as being full of fun. And crucial to that whole experience of palliative care for many people is the relationship with patients and families, holistic care, and the interdisciplinary team. Nurses and other healthcare professionals talk in terms of the privilege of helping people to find meaning in suffering, experiencing positive relationships and supports from colleagues, feeling that they've made a really positive contribution. So these are a number of the kinds of things that keep us going in this work.
Right. And I'm assuming that people who experience that don't have a problem with burnout then.
No, they don't.
They are able to carry on.
Yeah.
So why do we need to pay attention to ourselves? I mean, we're looking after patients, we're doing a good job. Why is it that we need to pay attention to us?
Well, I always use the analogy of making sure you have money in the bank. And, you know, it's okay to be putting stuff on your Visa. It's okay to be putting stuff on your credit line. But if you're just constantly going into debt and not making any payments, you don't have anything to give. And so we need to realize that you can't give from an empty vessel. And if we're not somehow filling ourselves up, we get into difficulty. There's a concept that I've been using fairly often, which is a story from the Talmud. And the question is asked, how can we know the Messiah? He's sitting among the poor covered with wounds. The others unbind their wounds all at the same time and then bind them up again. But he unbinds one at a time and binds it up again, saying to himself, perhaps I shall be needed. If so, I must always be ready so as not to delay for a moment. And it gives that concept, unless we're constantly filling up ourselves in some way through our clinical work, but also in our personal lives, there ain't nothing left to give. And so we need to be paying attention to making deposits in our bank in terms of good diet, exercise, social support, enjoyable activities that get us out of the work situation, time in nature, and tending to our spiritual needs.
I think that probably leads very nicely into the next question. The title of this session talks about feeding your soul. So how do we feed our soul?
Well, one of the ways that I learned much more about feeding my soul was in my experience of developing cancer 9 years ago. And during this experience, I had a whole spiritual awakening, which we don't need to discuss, but it really got me in connection much more with the spiritual realm. And an image that turned out to be very important in my life is an image that comes from Hildegard of Bingen, who was a mystic in the 11th century. And she has an image which is called the Man in Sapphire Blue. And this is an image of a Christ-like figure with his hands outstretched. And Matthew Fox writes about this. And he talks about this as being compassion. And compassion is taking the energy from the heart and putting it into the hands. But what you see in this image is that from this figure's head, you see an opening, and you see these energy spheres around his body. Now remember, this is something that was given to a mystic in the 11th century, but It is the sense that if we can connect with the universe, we can let out the stress and we can bring in the good energy. That if we can make of ourselves instruments where we're really replenishing our system, we have much more energy to give. And we can do this in a whole variety of ways, through meditation, prayer, time in nature, energy work such as Reiki, healing touch, therapeutic touch, being in touch with the people who feed our souls, yoga, Tai Chi, Qigong, or whatever feeds your soul. It's coming to look at our own soul and figure out what it is and how we can best feed it so that we then have the energy to continue doing the work.
I know in a lot of the education sessions when we're teaching about hospice palliative care is people having a better understanding of who they are, what their values, what their beliefs are. So this sort of also would fit in that. You sort of have to be aware before you can probably feed your soul.
Absolutely.
Be aware of what that is for you.
Absolutely.
Right. How you would define that.
Absolutely.
Right.
And it's coming to understand ourselves. So often we don't. We look to understand patients, and we put lots of labels onto patients' coping mechanisms and all this sort of stuff as a way of sort of getting an intellectual understanding. But we need to get a sort of gut-level understanding of both the patients and ourselves.
Right. And we need to really understand who we are to be able to continue to do the work and to provide the support for others.
Absolutely.
Yeah, you need to take, I know the saying, take care of yourself if you want to take care of others.
Absolutely.
Take care of yourself first, right?
Absolutely.
I think what I'm going to do now is I have about 8 questions that were sent in on the registration from people from throughout the who are listening. So I think I'm going to ask those questions because I've gone through them and some of them you haven't answered.
Okay.
And I think that's what we'll do next. We're sort of a little bit quick with what we've talked about, but I think this will sort of help. The first question comes from Heather Hart. She lives in St. Stephen in New Brunswick. And she said, the husband of a nurse who is recently retired is very sick. All the staff know the couple well. This will be very difficult. How do we comfort each other?
Well, if we're talking about how do we comfort each other, or are we talking about comforting the person whose husband is sick as well? So let's
do both.
That's okay. It's important that we recognize that we have great difficulty when one of our own is experiencing a serious illness or death, because there's often the feeling that that happens to everybody else. Val from Mount used to say, yea, though I walk through the valley of the shadow of death, it ain't never my fault, my turn. Okay? we think in terms of if I get sick or die, like
right.
This is an option of dying. So we need to recognize that this can happen to all of us and that this makes us aware of just how vulnerable we are. And we need to share it as a group. So we need to be able to talk about it. We need to be able to reach out to the person who is experiencing this illness of her partner and figure what are the practical kinds of things we can do. I think just this morning I was reading in the Globe about somebody who had cancer and people just spontaneously doing things for her. Don't ask, what can I do? Just do whatever it is that you can do. And people can accept that or not. But it's often helpful for caregivers to perhaps do a roster to be helpful to that person, of going and sitting with the person's husband, of bringing in food, because it gives us a feeling that we're in this together as a community, to be able to talk about our feelings of this is happening to one of our colleagues, it can happen to us as well. Sometimes this is where people's spiritual belief systems come in. Another thing is hopefully it makes us recognize today it's not my turn. So what can I do in my own family situation to celebrate the fact that we're experiencing good health while I reach out to my friend who is experiencing the illness and potential death of her husband, realizing that I too am going to have my turn, and I hope that others will reach out to me in the same way. It's that golden rule, do unto others as you would have them do unto you.
As you were talking about this, I was thinking that one of the things that you mentioned is the importance of actually your relationship and the building of the team. Can you give some practical ideas of, if you're working within the concept or the confines of a team to provide palliative care, and that's hopefully everybody is, what is it that you can do to develop that team so that you can support one another?
Well, I think the first thing to do is to recognize that not everybody is a team player. Some people are very involved with their own egos and only want to be a team player to the extent that I'm going to look good. And so we need to recognize that we have these aspects of our personality. Recognizing that, one of the things that's important is to realize that everybody on a team has his or her own gifts to bring, and these gifts are different, and that each gift has to be valued. And very often we don't recognize the value of the gifts that each of us brings to the team. And we need to work together in teams, listening to one another's philosophies. A recent article I did, I asked somebody to join me in doing the article, and he gave an example of a team that he worked on, and he found it very helpful every day to do a check-in with team members. So we were recognizing at the beginning of the shift that each of us is a human being, and each of us comes in with our own experiences of the day, and feeling that there are others who care about us as individuals and that we're heard in our team, then allows us to go out and listen to the problems of other people.
Mm-hmm, that makes sense. Mm-hmm.
Enjoying activities together, having social activities together, but not to create a situation where the team are your only friends. Some hospice teams get to socializing only with themselves, and that can get to be a bit too incestuous. You need to have outside friends who can talk about things other than death and dying as well.
Right. Yeah, that makes sense as well. Okay, so the next question comes from Kathy Chauvin from Windsor, Ontario, and I think that you've already answered this, but I just wanted to mention it so she's aware that we've gotten the question. She says that working with palliative clients can be very stressful for nurses. Any suggestions to prevent burnout? And I think that, is there anything else you want to add that you haven't already said about preventing burnout?
Well, I think we really should be keeping track of the kinds of things that we're doing. Somebody I interviewed for my book on stress many years ago said that she sat down one day and she assessed, what does Susie need? And she really put it all out there. She put out food, sleep, exercise, sex, time on her own, time with other people, all the things that were important to her. And she posted that on her refrigerator. And every time she found herself feeling somewhat out of sorts, she would look at that list and see what she wasn't doing. And I had a wonderful experience of running into this person probably 25 years later, and I said, oh, I remember when I interviewed you for my book, and tell me, do you still have that list on your refrigerator? And she smiled and she said, yes, I do. Okay? So it's these tried and true kinds of ways of keeping in touch with ourselves that can be really helpful. And you have to decide what it is that keeps you going and make your list and see whether or not you're meeting those needs.
That's good practical advice.
Yeah.
We have another question from Joanne Hurley from Lloydminster, Saskatchewan. She says, hopefully this will address the stress for caregivers with young palliative clients. So I'm assuming that they look after young people, and she finds that very stressful. So is there anything in particular that you could provide for her or give her for this?
Well, much of my work is with young people. And one of the things that I learned early on from Avery Weissman, who was a mentor, was the concept of the least possible goal. And when we're feeling really overwhelmed, as we're dealing in these tragic situations, to think, what is the least possible thing that I can do in this situation to make it better for these people? And then if each of us is trying to meet the least possible goal, together, we can try to improve things in this very tragic situation. We need to have the time to be able to sit with colleagues if they're helpful, or perhaps getting an individual therapist or supervisor to reflect what dealing with young people who are dying is doing to us. Often, if you're also young yourself, there's going to be a real sense of, this could happen to me, this isn't fair, and we need to be able to have supervisory relationships in which we can really work through our feelings about this and come to understand, true, it isn't fair, but if I get lost in this isn't fair, it's not going to be much help to this person. So what can I do to work with my own feelings so that I can be more available to helping this young family deal with their feelings?
Right. Yeah, that's that need to understand what you're feeling about first, so that you can provide that support.
It really is, because often that will make us get really distant from people, so we won't get involved, and they'll feel, not only am I going to die, but this is a big problem for the professional caregivers, and so they're not even capable of coping with me.
Right. Sylvia Keel from Moose Jaw, Saskatchewan wants to know if there's any information or research indicating whether nurses working in palliative care exclusively in the community have a higher burnout rate than those who work in the community on home care with a mixed caseload of probably long-term or acute or plus palliative.
I'm not aware of any specific research in that area. It's something that could be studied, and it could be an interesting study. Now, the people that Linda Christensen interviewed were primarily working in palliative care, but many of them were not necessarily doing it full-time. Some of them were doing it part-time. Some other research shows that people who do palliative care part-time have more stress and burnout than people who do it full-time. And the feeling is many people went into doing it part-time because they were feeling stressed doing it full-time, and so maybe the basic issues need to be dealt with. I think if you are constantly accompanying people to death without also being involved in life as well, it can be very draining for you. I know my own practice, and I've been doing this work for over 35 years now, but I have a practice primarily of people with cancer and bereavement, but I always am seeing people throughout the whole continuum. So I always have people in my practice who are newly diagnosed through survivorship, recurrent disease, palliative disease, bereavement. So that ability to see people through the whole continuum has certainly been helpful for me in keeping me going in the field for so long. So, there may well be advantages to a mixed caseload, but I think we'd have to really study it.
Because I'm thinking to myself, I know the challenges of having a mixed caseload in home care in particular is you may go out to see someone who's palliative and you're supporting them, and then your next visit is somebody who needs a dressing change, and then so it's like you feel like you have schizophrenia or something because you're flipping from one to the next. Yeah,
and yet if you can somehow manage to be totally present in each situation, that can also be helpful.
Right.
I remember a family doctor I interviewed one time saying that he tried to figure something in each patient that he could be attracted to. And if he couldn't find something he could be attracted to, then he would suggest that this person move on. So really actually getting into the experience with each person can be extremely helpful for us. But again, part of it is going to be personality-wise, and what is it that feeds your soul versus what is it that feeds somebody else's soul.
Right. Okay, and the next question comes from Connie Munston from Kitimat, BC. She's wondering how to deal with residents or families who are demanding attention, how not to take this personally when you're being criticized by residents or family, even though you're doing as much as you can.
Well, it's always tricky. And that's where, to some extent, without sounding simplistic, the ability to see oneself as an instrument can be helpful. And if you see yourself as bringing in the energy from the universe and sending it out, you can realize that, in fact, for this person, they may need to vent at this point in time. But if you're connected to something deeper within yourself or the universe, whatever you want to say, then that can help us to not take things so personally. And sometimes if you don't connect with anger, then people can sort of move up the sort of energy sphere, if you want to say it, with you. And, they will sometimes come back and thank you for being there and letting them do this venting that they needed to do, realizing it might or might not really have applied to you. On the other hand, sometimes there are things we do that staff have a right to get upset about. I was just talking to somebody who was very upset because his wife was screaming in pain on a palliative care unit, and the nurse he spoke to said it wasn't her patient, and I'll get your nurse. And the nurse came in and rubbing her eyes. It was a night shift. She had been sleeping. And when he spoke to her, she said, now I think we should really settle down here. And he was very angry about the fact that his wife wasn't getting appropriate pain medication. And, so he had a right to be angry in this situation. And, does the nurse have a right to be sleeping when she's on a night shift? Maybe that's the way things get organized, but people should not be screaming in pain on a palliative care unit without anybody there to help them.
Right.
So.
Okay. And I know that with venting, with anger, often the family, they're not angry at you, they're angry at the situation, and they just need to express it, and you just need to be able to let them express that.
Exactly.
Right. Deb Sheldon from, it's STE Rose. What is STE? What's the abbreviation for?
Saint.
Okay. Manitoba. She wants to know signs of compassion fatigue. Is there anything else you want to add about signs of compassion fatigue that you haven't?
It's that sense of essentially being an empty vessel, like there just ain't nothing left to give. And the sense of needing to fill that vessel. And one of the things we didn't get into talking about is the concept of compassion satisfaction that people are looking at now. In contrast to compassion fatigue and compassion and burnout, people are looking in terms of job engagement and compassion satisfaction. So sometimes if you're feeling compassion fatigue, look at some of the aspects of your work that are giving you compassion satisfaction. If she would really like to learn more about it, I've written about quoted Charles Figley and written about the difference between compassion fatigue, burnout, depression in a recent article. But the source for that, I think, is in the reference list in the book by Figley. And what he has done in his 2002 book, Treating Compassion Fatigue, is to look at the difference in the signs of burnout, compassion fatigue, and depression. And it's helpful for people to look at the sense that it is a continuum. But again, that sense of fatigue and just like there ain't nothing left to give, as opposed to the person who's burned out. The person who's burned out almost doesn't care and is distancing from patients,
right.
Whereas the person with, and has almost turned away from patients, is almost angry at patients, whereas the person with compassion fatigue is just feeling empty and needs to go away and replenish him or herself. So things like engaging in spiritual practices, listening to music, getting away for a weekend, going out into nature. These are things that can be helpful for filling the soul, and literally letting yourself know that you're filling your soul.
Right, great. Natalie Warmerdam from Richmond Hill, Ontario, she has a really good question. She talks about nurses are supposed to maintain professional boundaries while providing care. And what she's saying is that working in a small rural setting, how do you actually maintain boundaries and do your grieving and get support in a small community when everybody knows one another? How do you do that?
Well, this gets into a very interesting issue that I have a real interest in. And the bottom line is, what are the boundaries? And I think in palliative care, we need to be looking at some of these issues. In palliative care, we often don't maintain the kind of boundaries that people maintain in other aspects of medical nursing practice. And many people like Michael Carney, Rachel Naomi Remen, a number of other people, David Barnard, are talking about the fact that the boundaries between us and our patients, our clients, are not necessarily as clear as they used to be. And David Barnard talks in terms of whole person care, and that the whole person of the patient and the whole person of the caregiver is involved. And one can look at the fact that happens as well at an energetic level. Now, so given that we don't necessarily maintain the same kind of boundaries, if you need to be able to discuss the problems that you're experiencing being a nurse in a rural area, then it's helpful to have other people that you can discuss it with. So maybe you have a small core group of colleagues that you can discuss it with, or it's the kind of situation that perhaps could be discussed, say, with groups of nurses in rural areas. Figure out, you probably can't do it on the web because it's not totally confidential, but some of the relationships that develop on the web could perhaps lead to people developing relationships in which they could have phone support groups or some other way of being able to talk to other people in similar kinds of situations.
That's a good suggestion. I'll open it up for questions from the audience. Hi, Tammy.
Hi, Mary. I was wondering about, because when you were talking about sort of self-care, and I heard so many times, okay, these are the things we need to do to care for ourselves, and yet there's those of us who just don't get to it. So I was wondering if you could talk about some strategies in terms of how do we make this important enough for ourselves to actually do, and then what can we as individuals do to support each other and the institutions that we work for identify this as a priority so that we can care for each other in that way?
Well, I mean, I think that's where the check-in on a daily basis can be really helpful. And this comes from a nurse who was working in BC when they started doing it. And what happened was the bereavement group, when they met, did a check-in. And so the staff thought, golly gee whiz, maybe we should be doing a check-in with each other. And he found that it really made a significant difference that people checked in with each other on a daily basis. Now, what about self-care? Again, do we really feel that we are worthy of our own care? Or do we only think that patients are worthy of good care? And there's a self-esteem problem with many people in nursing, and we really don't value ourselves enough to feel that we deserve this care. I can proudly say that I'm doing various aspects of all of the things I'm talking about. Now, yes, it's taken me a few years to be in a place where I am doing all the things I'm preaching about, or enough of them to maintain my own balance. But it really comes to recognizing that we have a responsibility, and there's some of the stuff that I've worked with talks in terms of there's an ethical responsibility to care for yourself in order to be able to care for others. So I think this concept of actually writing your own list of what it is that you need to care for yourself, what is it that keeps you well-oiled and functioning, and looking at your list when you're not functioning very well. And with regard to organizations looking at it, one of the things might be, if you do check-in, just everybody saying what is something that they did to take care of themselves yesterday. Another way of keeping groups functioning better is to give praise to one another. A very simple kind of thing, but that concept of rewards, to comment. People talk in terms of using yellow stickies to say, thanks for the great job that you did with so-and-so yesterday. To reinforce each other can really be helpful.
Next question.
Wendy here. Comments, please, on the blending or melding of the boundaries when working in palliative care. If you could speak a little more on that, please.
Well, it's a tricky question, and this is something that I became very involved in as I had a sense of spiritual connection with others who had died, who had gone before me, when I was experiencing my own cancer experience. And this was totally alien to anything I knew or understood about, but it was as though I was walked through the experience, as I say, by people from the other side. And eventually I came to understand it as something that could be called a connection with the communion of saints, a connection with the mystical body of Christ, if you want to use some theological terms. But it made me aware of just how much we are a part of one another. Now, I have gotten into some difficulty talking in terms of some of these concepts because some people feel that we must have very clear boundaries between ourselves and our patients. But I think of us and our patients as being on a mutual journey. And Michael Carney talks in terms of Jung's archetypes of the healer and the patient, and that within each healer is a patient, and within each patient is a healer. And if we call us nurse healers or, whatever you want to say, but if we as nurse healers do not recognize that there is a patient within us, then we cannot reach out to enable the healer within the patient to function really well. That this is much more of a mutual process. And if you want to look at some of the nursing literature, Jean Watson's work and Martha Rogers' work would be ways of understanding some of the differences in the boundaries that we talk about. Now, that does not mean that we're going to get inappropriately involved with people, and that's, so we're not going to be getting into some kind of sexual contact with patients' families. We're not going to be dumping our problems onto them, but we are going to recognize that we are human beings sharing an experience, and that I am not, as the nurse, the healthy nurse, all that distant from my sick patient. We are together learning from one another. This is a mutual interactive process. And I think very often if we come to look at some of these issues, we see that some of the lessons that come to us through the patients that we work with are lessons we're needing to learn in our personal lives. So it gets us into some of the sense that this work can indeed feed our souls, can in fact serve our souls. And, we could talk much more about this, but those are some of the ideas about it. And I think it's a kind of issue that might be good to take to your group.
So what I wanted to share with you is a take-home message that Mary provided for us. Palliative care is whole person care. The whole person of the patient and the whole person of the nurse is involved. If the nurse doesn't care for her or himself, then she has nothing to give to patients. There are specific signs of burnout and compassion fatigue that one can watch for in oneself and in colleagues and take action if these signs are present. And feeding one's soul and also one's body and mind can help to maintain energy to continue to function in the field of palliative care. Mary, I would like to thank you very much for joining us today and to sharing with us some ways to take care of ourselves and to feed our soul.
This has been a Pallium Project Professional Development Podcast. For more information on the Pallium Project, including written transcripts of this session, please visit www.pallium.ca. Pallium.